All right, good morning. Good morning, good morning. Let's let everybody come in from outside. We'll get started. Well, hopefully everyone slept well and let everything from yesterday percolate. What an incredible day we had yesterday, right? So now today we're going to put all of that together that's been percolating in your brain. And this morning we're going to start things off with really a session focused on what are the opportunities and challenges to delivering this kind of care in different settings, with different competencies for physicians and through different technologies or different sort of ways that we might accomplish this. So with that said, I'm just going to launch right in. And our first speaker is Crystal Denlinger from Fox Chase, who's going to be talking about incorporating weight management and physical activity in cancer survivorship care from the clinical perspective. Thanks, Crystal.
Good morning. I'd like to thank the organizers for inviting me to speak at this meeting. And in full disclosure, I'm a GI medical oncologist and also someone who probably doesn't always meet all of their physical activity recommendations on a daily basis. So I'm going to start with a story. In my early career, I was a breast cancer doctor as well. So I'm going to tell you a story of a patient of mine that I've been following through the last 8 years, more from the perspective of what it's like to be a clinician. So this was a 48-year-old woman when I met her in 2008, and she was diagnosed with a stage 1 estrogen receptor, progesterone receptor positive breast cancer, and she was also found to be a BRCA2 carrier. So she was treated with bilateral mastectomy and received adjuvant aromatase inhibitors for 5 years. And because of her BRCA2 status, she underwent a prophylactic bilateral salpingophractomy and total abdominal hysterectomy. At the time that I met her, she had a BMI of 35. And I followed her for 5 years according to guidelines. She saw either myself, her surgeon, or her, basically myself and her surgeon every 3 months for the first 2 years, and then every 6 months to complete 5 years. And then I've been seeing her annually since then. So when I met her, we talked a little bit about weight. Obviously, at the time, her BMI was rather high. And at diagnosis, she was very stressed. And I said, we really should be thinking about physical activity, weight management. And at the time, both of us agreed that this was not the time to really take on weight management because we were dealing with the fact that she had a life-threatening diagnosis. She was working full-time. She had a young child. There's lots of things going on. When she was on aromatase inhibitors, her BMI increased. And while she was on therapy, her reasoning was that therapy was actually making her gain weight. She had arthralgias, so she had difficulty walking. She had excess weight gain on the AI therapy, which is a known association with both breast cancer and AI therapy. And we talked about it again and again. And at the time, for those 5 years, she really didn't have it in her and continued to say, it's the treatment. And then I started seeing her annually, and by that point, she had tried Weight Watchers, she had tried medications, she had done everything that she thought she could do, and nothing was working. And so I continued to say to her, yeah, but we really should talk about weight loss, and you should lose weight, you should be exercising, but my nurse was calling and my pager was going off, and so we didn't spend a huge amount of time discussing it. And then she was diagnosed with prediabetes. And her primary care physician started also saying to her, you really need to start losing weight. This is an issue. So she finally came in one day and she said, Dr. Denlinger, I went back to Weight Watchers and I hired a trainer. And I was like, really, that's terrific. Congratulations. Keep up the good work. And she's one of the few patients that I actually email with. And so during her treatment with Weight Watchers and the trainer, she would email me her progress. I'd encourage her, just congratulations, good luck. And over the course of the last 2 years, she's lost about 20 pounds, and she's now exercising regularly. And I just got an email from her while I was at the meeting that she is no longer pre-diabetic, which is wonderful, but it took almost 9 years of me talking to her, of her going through lots of various excuses, and for me going through excuses. And we'll talk about what some of my excuses were when I was discussing this with her. So let me tell you a little bit about the survivors that we're seeing in the clinic and some of the challenges that we face. So there are over 15 million survivors as of January 2016. And most of those are actually more than 5 years from diagnosis, which means that they're not always following up with oncologists. I'm a GI oncologist by trade now, and at the end of 5 years, my patients typically go back to the community, or maybe I see them once a year. So they're not touching oncology all that often. In addition, my survivors are mostly on the older side. The majority of survivors are over the age of 50, which means they're dealing with other medical issues and other medical problems outside of just their cancer. They're also a very heterogeneous population. They're not all breast or prostate cancer survivors. And in fact, in my practice, I see survivors of esophagus, gastric, pancreas, colon, rectal, anal, and everybody has a slightly different need or a slightly different sort of survivorship profile. The reality is that they also have comorbidities. They're not just dealing with cancer, they're dealing with multiple other comorbidities, the most common of which are musculoskeletal or cardiorespiratory issues. And they report poorer health outcomes and a higher need for help with activities of daily living than the general population. They're also at higher risk for non-cancer causes of death and second primary cancers. So as you get older and you get farther away from your cancer diagnosis, the number one cause of death in a cancer survivor, the further out, actually ends up being cardiovascular disease. So that they're not, they survive their cancer, but still have cardiovascular disease as their biggest issue. And I like the person yesterday who said when they were diagnosed with breast cancer, their oncologist said the number one cause of death in women is cardiovascular disease. And I think that that's important to remember. And for those who go on to develop a second primary cancer, they're not developing it within the same organ system, they're developing it somewhere else. And lifestyle actually can play a role in the shared etiology of both of their primary cancers. They're also dealing with late and long-term effects. So late effects are effects that come out after treatment is done. Long-term effects are things that happen during treatment. Patients are sort of compensating for them, and then they persist. And that can include things like impaired organ function in my population. That could be impaired bowel function, impaired eating. It could be neuropathy from drugs like oxaliplatin or Taxol. There's psychosocial distress, anxiety, relationship changes. There's sexual dysfunction, genitourinary dysfunction, infertility for those that receive pelvic radiation, or for those women who are men who are receiving different kinds of chemotherapy. There are cosmetic changes. You lose a breast, you gain an ostomy. Those are actually issues that are permanently changing who you are. There may be mobility limitations, communication issues, cognitive changes, and then of course there's the practical and financial side of it, where if you were 49 with diagnosis, can you go back to work? How do you deal with the fact that you have a family? Survivors are also not likely to engage in healthy lifestyle behaviors the way we would like them to. According to the most recent data from the Behavioral Risk Factor Surveillance System and the National Health Nutrition Examination Survey, only about a third of survivors are physically inactive. They're more likely to be sedentary and be sitting for at least 8 hours a day. Up to 2/3 are considered to be obese or overweight, and most, including most survivors who are trying to make dietary changes, are not necessarily consuming the number of recommended fruits and vegetables per day. So we know these guidelines. These are the ACS guidelines that have been endorsed by the NCCN. They are, in theory, very easy to talk about and very easy to endorse, but I can tell you as a clinician, that's not always the case. So we've done a study, and I'm going to talk about the UNC study, which was discussed yesterday as well. The top two graphs are a study that the NCCN Foundation supported for a Young Investigator Award that I did a couple years ago, and we looked at adherence to the principles of survivorship that are published in the NCCN Guidelines for colorectal and non-small cell lung cancer in our academic center and our community affiliates. And we looked at 19 different practices, which was 71 oncologists or advanced practice clinicians, and it was 895 charts. We did a chart review. We went and talked to them about why this is important, and then we went back and re-looked at their charts. And sure enough, in the colorectal population, less than 20% of charts had some documentation around physical activity discussion or healthy diet counseling. In non-small cell lung cancer, they were better, but that declined over time, even after I went out and talked about why that was a good idea. The UNC study found similar results, that only about 1/3 of encounters had some documentation around physical activity. And even though it was documented in 35% of the time, only 7% of after-visit summaries had some sort of discussion. So it could have happened in the office, but the patient didn't walk out with any sort of lasting reminder. So providers do think that this is a good idea. In fact, most oncologists believe that physical activity, exercise, health behaviors, changes, weight management is beneficial, important, and very safe, but we only spend about 5 minutes really discussing it in the course of clinic, and about 1/3 of us don't believe that patients should be exercising while on treatment. And in fact, few survivors actually recall being asked or advised about health behaviors. Sabatino published a study back in 2007 suggesting that about 10% of survivors recalled a discussion of all 3 health behaviors, and at the time that was diet, physical activity, and smoking. And in fact, the further away you got from diagnosis, the less likely you were to have a discussion about these health behaviors. So it is a teachable moment early on, but it's still a teachable moment over time, and that time gets wasted. So provider recommendations do matter, but I'm not 100% convinced that it's just a provider recommendation that's necessary. And I'm going to contrast two studies here. So Lee Jones did a study looking at newly diagnosed breast cancer patients, and the recommendation was that side effects can be improved with the use of routine physical activity, and that the oncologist recommended physical activity every day if possible. And in fact, that increased physical activity engagement. It increased the number of patients who were meeting guidelines, but still 41% of the patients incorrectly recalled the recommendation or whether the recommendation had been received. A second study out of Korea looked at breast and colorectal cancer survivors. So these are patients who are through treatment, and this randomized patients to either usual care and a doctor's recommendation or a doctor's recommendation with a motivation package. And again, the wording was very similar. This can reduce your recurrence, you should participate in exercise, and the motivation packet was an exercise DVD, a pedometer, education, and a diary. If you added the motivation packet to the MD recommendation, there was an increase in moderate intensity exercise and in the total amount of exercise that survivors engaged in. It improved role function and decreased pain and diarrhea. But if you were a survivor who just received a recommendation from your physician, there was no benefit or no increase in activity compared to those who had usual care. So in survivors, it may not be enough to just say you should do this. We may need to be doing more. So there are a lot of barriers, and I'm guilty of having some of the same barriers that the survivors have, plus having those barriers as a provider. But the most important barrier, I think, is lack of time. And you all probably have the same barrier I do. Finding the time to go exercise can be hard when you have 8,000 other things going on. But that's actually true in the clinic encounter as well. There's only so much time in a clinic visit, and we have a lot to cover. There's also potentially a lack of access for patients or lack of referrals. So for survivors, they may not have access to healthy food options if you live in an inner city or in a very rural area. You might not have access to a safe exercise facility if you live in North Philadelphia, where Temple is located, and that's one of the hospitals we're affiliated with. It's not exactly easy to go outside and exercise. And we as providers may not have the right support. We might not have the right referral options. We may not have good strategies to send our patients to. We don't necessarily have the reimbursement for discussion, and it's really hard to do all the documentation. There's also a lack of messaging from providers. There might be unrealistic demands. You know, if somebody was completely sedentary, telling them that they should go out on walk around the track, bad idea. We might recommend them to go exercise and change their diet and stop smoking and stop drinking all at the same visit, and that's way too many recommendations at once. And as a provider, I don't necessarily have that expertise. I don't have a lot of training in medical school on how to do this, and I may actually make unrealistic expectations because I'm looking at the guidelines but not really understanding how to implement them. Treatment effects can obviously alter someone's ability to participate in diet and exercise changes, and risk to patients. You know, we have providers that are concerned about the possibility of weight loss, especially in survivors where weight loss could signal recurrence. There's also a lack of motivation on the part of both the survivor and the provider. Is this really important? Skepticism about whether it's actually beneficial. In the provider side, maybe lack of knowledge, I would say on the patient side as well. And then there are cultural barriers, body image barriers. We hear this all the time in my clinic. If I just got a little bit more weight back on me, I would look better, even though they're actually still in need of additional weight loss. And there may be unsupportive family and friends that would prefer that their survivor be someone with a little bit of extra meat on their bones. There's also competing needs in survivorship care, and these change over time. So in the acute phase, which is during that first year, as an oncologist, I'm talking about the treatment, we're making plans for care, we're talking about side effects, you know, maybe we're talking about rehabilitation, but we're doing a lot in that first year. Then we get into the surveillance piece during the extended phase of survivorship, where I'm seeing them less often. We're doing more periodic assessments, but during that time we're talking about surveillance. We're doing side effect management still, psychosocial issues, and dealing with the sort of emotional fallout of the cancer. And then we get into that permanent phase of survivorship, which in my clinic tends to be around 5 years out. And at that point, I'm more interested in cancer screening, late effects detection, and then through all of that, I'm supposed to be talking about healthy lifestyle behaviors and comorbidity management. So there's a lot to do, and all of that needs to happen fairly quickly. And this is my typical clinic visit. I have 15 to 20 minutes, and my agenda is not only being social and asking how you're doing, but how are you feeling? We have to go through an assessment and management of treatment effects, and in GI cancers, that can actually be very burdensome. We need to know what's going on with the cancer, so we have to go through all the surveillance imaging, the blood work, the physical exam, vital signs. We usually ask about overall health, including what cancer screenings people are getting, because even though they have had an esophagus cancer, they still may need a mammogram and a colonoscopy. And usually there's at least one non-oncology issue that comes up. You know, Dr. Smith told me I needed to start taking cholesterol medication. Dr. Denlinger, what do you think about that? And then we have to plan for the next visit, which nowadays with the EMR entails me spending time at my computer, writing a bunch of orders, figuring out where the paperwork went, pulling up that after visit summary, and then getting that delivered to the patient. Now we have to do that 9 to 15 times in a half day, and then there's a new patient usually seen in there as well. So if you do all of those things, it's difficult. In addition, there's a lot of other distractions. Your pagers are going off, your clinic staff has questions, the telephone triage nurses are calling you, you have trainees that need to learn something, the nurses are doing things, education, they're managing your orders, they're scheduling. And don't forget, you have to document all of this. So when we're talking about the fact that this is sort of easy to do, I can tell you as a clinician, it's actually not as easy as we think it should be. And in addition, local resources can be hard to find. So in preparation for this talk, I live in Philadelphia, so I decided to walk around where I live and ask people about their resources. I went to my gym, which has supposedly the best number of trainers, the best staff of trainers in Philadelphia. There's over 20 of them, and I couldn't find anyone who focused on cancer patients. In fact, there were few health and wellness programs. I actually asked my Facebook friends, many of whom are either trainers or oncologists, and there were really few programs. They identified the Livestrong at the Y. There were a couple of health and wellness centers that were associated with health systems, but those were in suburbia and not necessarily in Center City. There were some Livestrong programs. I actually had to Google in 2 different places to figure out that there's a Livestrong program near my cancer center. But my patients come from all over eastern Pennsylvania, southeast New Jersey, Delaware, so it's hard to know who lives where and where those resources might be. And if you go to a smaller private gym, you might not have any resources at all. And in fact, when I went to the management of my gym and asked them about cancer resources or cancer survivorship resources, I kind of got a blank stare. So even though there are really national guidelines and resources, it's difficult on an individual level. So I chair the NCCN Survivorship Guideline panel, and I thank them for these slides because we have tried in our guidelines to not only talk about physical activity and endorse the ACS guidelines and the ACSM guidelines, but to try and figure out ways to make them more implementable. And so there's assessments that we have recommended kind of going along the 5 A's, but there's a lot to assess when we're talking about physical activity. And we've tried to find ways to really like define who's somebody who's not at great risk, someone who might be at moderate risk, and someone who might be at high risk, and try and figure out how to triage those patients in terms of those at no significant risk, just go out and exercise or get involved. And if you're somebody who might have some mild or moderate toxicities, you may need the help of an exercise professional, and obviously someone who has a lot of toxicities or ramifications of their treatment or other pretty significant comorbidities that they need the help of an exercise professional. And we've done similar work with weight management and nutrition. We've tried to add into our algorithm ways to implement these recommendations because it became clear when we were writing the guidelines that we needed guidance in how to do this. And so we've used an algorithm to try and talk about ways to implement them, which really works, which really recommends short and long-term goal setting and incremental changes. And then we've included things like strategies to increase physical activity and guidance for resistance training recommendations, as well as some guidance for weight management. And so we're working as well to try and figure out ways to make these more implementable in line with other NCCN disease-specific guidelines. So there are some facilitators for health behavioral change. If you and your survivor both have a positive perception of change in behavior and the benefits of it, then you're more likely to both recommend it and also participate in it. Recommending and making small achievable changes is probably the most important thing. And also obviously having easy access to either referrals or resources, having the support of providers or being a supportive provider and messaging from multiple people is very helpful, and fear of recurrence is a really strong driver. Obviously, having accountability, being self-motivated, also very important from the survivor perspective in getting involved in health behavior change. So there are a bunch of resources out there. This is called from the NCCN resource page, but a lot of these are on the web or in ways that you can find resources through the internet. Live Strong at the Y, I think, is a great program. I wish all of the gyms had this program. But there are a lot of resources nationally. It's actually kind of hard finding them in a local place. So back to my patient. So some of the barriers we faced is that she believed really she couldn't do it. She was dealing with side effects of her treatment, and she really wasn't fully committed, but either was I. So I would see her in clinic. I'd have a lot of stuff going on. We'd talk about things, but it was really just a few seconds of our visit. There was really a lack of time, both on her part and on my part, to really explore what was going on, and really a lack of knowledge of the resources. She had done Weight Watchers, she had been on medication, but I didn't know what else we could do. And then I finally started seeing her every year. So once a year I would meet with her. And that was also challenging, because if I only see her once a year, how often can I follow up? There were some facilitators, and that was that the primary care physician and myself were both finally saying to her, you need to do this. She was afraid of the consequences. Diabetes is a really big motivator for her. And she was accountable. She got a trainer, she showed up at Weight Watchers, and she had accountability. And finally, she had the support of both us and her family, and I think that's what made it work. So in conclusion, getting cancer survivors engaged is hard. It's not an easy thing to do as a provider, and there are a lot of barriers that exist. Time, motivation, access are all really important. We actually need some resources to overcome both the provider barriers as well as the survivor barriers. How do we overcome that lack of time? And then finally, there are resources that exist that may be hard to identify or to access. So I want to thank the NCCN for their support, my patients and colleagues for being supportive too, and actually my trainers over the years, because they've been really helpful in answering a lot of my questions. And thank you for your attention.